Hello friends, welcome to my channel. Today we are going to discuss about the clinical case 3 from the abdomen. A 38-year-old man was carrying furniture out to a van in preparation for his family's move to a new home. When he strained to pick up a particularly heavy table, he suddenly felt sharp pain in his right groin over here. He noticed that a painful bulge had developed in his groin which disappeared when he lay down on his back. He did not like going to the doctor, so he ignored the condition. After several months, the pain and the bulge in his groin increased, and he finally consented to see a physician. On examination, the physician observed a swelling above the median point and then turned toward the scrotum. The physician made a diagnosis of indirect inguinal hernia and scheduled for surgery. The hernia was successfully repaired and the patient was discharged from the hospital a few days later. Now we have seen the clinical condition. Now the questions goes like this. What abdominal wall layers must be incised in order to access the abdominal cavity? Let us see that. So in this picture, we are going to see from outside to inside. The first layer is the skin. Now beneath the skin, you can identify this yellow color layer that is called as Camper's fascia, which is a superficial fatty layer. Now underneath this Camper's fascia, the membranous layer can be seen that is called as Scarpa's fascia. Beneath this Scarpa's fascia, we can identify external oblique abdominis aponeurosis. Now, beneath the external oblique abdominis aponeurosis, here you can identify the inside one is internal oblique abdominis. Internal oblique abdominis. Now, beneath the internal oblique abdominis, you can identify the transversus abdominis muscle fibers. Now, beneath that, we can identify this fascia is called as fascia transversalis. Beneath the fascia transversalis, you can identify the extraperitoneal connective tissue. There is a fatty layer, extraperitoneal connective tissue. Then beneath that, you can identify the parietal peritoneum. So there are 9 layers can be seen from outside to inside. We have seen skin, campus fascia, scarpa's fascia, external oblique abdominis, internal oblique abdominis, transversus abdominis, fascia transversalis, then extraperitoneal connective tissue, then after that parietal peritoneum. These are the layers we have to incise in order to reach the abdominal cavity. The second question is, what defines this hernia as an indirect inguinal hernia rather than a direct inguinal hernia? Now observe this picture. We are observing and the clinical condition in the last slide we have seen that hernial sac which is present from the midinguinal point to the scrotal sac. So we can suspect that it might be indirect inguinal hernia. For that we can go for the cardoplanar as well, but easily we can find out that in entire the inguinal canal the hernial sac is present. So we can suspect it is approximately it is the indirect inguinal hernia, because at the 2 centimeters above the midinguinal point where we can find out the deep inguinal ring which is present on the fascia transversalis. So the hernial sac is entering in this deep inguinal ring and then it is extending outside through the superficial inguinal ring and then it reaches to the scrotal sac. So this is how it enters and exits. You may get a question like, then what about direct inguinal hernia? So you said direct inguinal hernia is extending from deep inguinal ring to the superficial inguinal ring that is in the inguinal canal. Then what about direct inguinal hernia? So in this direct inguinal hernia, we need to understand the Hasselbalch's triangle. You don't worry about it. Hasselbalch's triangle is nothing but the triangular area is present medial to this inferior epigastric artery or above the inguinal ligament. Inguinal ligament, as you know, that it is extending from anterior superior iliac spine to the pubic tubercle. That is nothing but your inguinal ligament. Above the inguinal ligament, we have discussed about the abdominal wall muscles. So oblique muscles we have discussed. Then vertical muscles which are present, those are called as rectus abdominis muscle fibers. So those are called as six pack and eight pack muscles, as you know that. Now the triangular area which is present lateral to this rectus abdominis muscle, medial to the inferior epigastric artery, then above the inguinal ligament. So this is a triangular area. This triangular area is called as Hasselbalch's triangle. Now what are the boundaries? Medial boundary is lateral border of rectus abdominis muscle. Lateral boundary is inferior epigastric artery. Inferior epigastric artery that we have seen in the previous video. You can find about that. Now base is formed by the medial half of inguinal ligament. So this triangular area is called as Hasselbalch's triangle. So due to the weakening of this particular area, the abdominal contents, the loops of intestine or the bowel, they enters into this Hasselbalch's triangle and comes outside. So that's how we can differentiate. If the bulging is present medial to this inferior epigastric artery, that is called as direct inguinal hernia. Indirect inguinal hernia means if the hernial sac is present above the mid-inguinal point, if it is passing through the deep inguinal ring, and that is called as indirect inguinal hernia. Thank you. Now, what caused the bulge? What body layers would surround it as it proceeded into the scrotum? And what abdominal layers are they derived from? Let us see that. Now, let us see that in this inguinal canal, we can identify the loops of intestine can be seen. Loops of intestine, they are entering into the deep inguinal ring and they are coming outside through the superficial inguinal ring and they are going to reach to the scrotal sac at the right side. Now we are going to see in that bulge when you give incision and try to identify inside that what are the layers can be seen. So from outside to inside, obviously skin is present. Beneath that, you can identify as we are giving incision in the inguinal region and then the scrotal sac, we can find beneath the skin is a dartos muscle. Underneath the dartos muscle, we can identify the membranous layer of superficial fascia, that is Scarpa's fascia. Then beneath that, we can identify, so this is a hernial sac, and here you can identify this is nothing but your external spermatic fascia. This external spermatic fascia, underneath the Scarpa's fascia, we can identify this is the continuation of external oblique abdominis aponeurosis. Then what about beneath that? We can identify the cremasteric fascia. The cremasteric fascia is nothing but the continuation of internal oblique abdominis. Here you can identify this is the external oblique abdominis muscle, that is a aponeurosis of it is continuing as external spermatic fascia. Beneath that we can identify this is the internal oblique abdominis. The aponeurosis of this internal oblique abdominis is continuing as the cremasteric fascia. Then beneath that we can find the internal spermatic fascia. This internal spermatic fascia is a continuation of fascia transversalis. Here you can see this is a layer, fascia. Now the next question is, why would it be necessary to repair a hernia like the one described above as quickly as possible? Let us see that. Now try to observe this condition. You can see that an indirect inguinal hernia in which the bowel means the intestines, this obviously sometimes most of the times the small intestine comes and sometimes the large intestine may enters in the inguinal canal. So that bowel becomes entrapped can rapidly lead to an intestinal obstruction and strangulation of the loop of bowel protruding into the inguinal canal. Here you can see that the protrusion of the inguinal canal. If it is not treated immediately, gangrene of the intestine may set it in almost in a 12 hours. You can find that. You can see that gangrene is in dark color. So such type of thing is called as strangulation, or it might be called as obstruction. This intestinal obstruction can be seen. That's why you have to go for repair as soon as possible. The next question is, which structures passes through the inguinal canal in the male and in the female? Let us see that. Now we have seen the structures passing through the inguinal canal in the male. This is the male specimen. We have taken a transverse section and trying to observe that. This is the urinary bladder, and lateral to that we can identify these structures which are passing through the inguinal canal or the spermatic cord. Spermatic cord, it is also consisting of testicular artery, pampiniform plexus of veins can be seen, and also we can identify ilioinguinal nerve also passes through the inguinal canal in the case of males. Then what about females? Now this is the female pelvis transverse section, and we are trying to see what are the structures are passing through that. So in the females we could not find that spermatic or so. We can find the round ligament of uterus can be seen. A round ligament of uterus can be seen in this inguinal canal. And also the ilioinguinal nerve is a common content in both sexes, male and the female. So you can write it as ilioinguinal nerve and round ligament of uterus in the females, spermatic cord in the case of males. So in the spermatic cord, you have to mention ductus deferens or vas deferens, testicular artery, pampiniform plexus of veins. So that is about your inguinal canal clinical case. See you soon with the new class. Bye bye.